Welcome to this explainer. Today, we're diving straight into a high-stakes, literal ticking clock scenario that plays out right inside the human abdomen: acute intestinal obstruction. Imagine your body's internal plumbing system just suddenly backing up. It's not just a simple mechanical failure. If it's not intercepted, it triggers a rapid, terrifying cascade toward tissue death.
You know, in the world of surgery, there's a classic adage that perfectly sets the stage for us. It goes like this: the sun should not both rise and set on a case of unrelieved acute intestinal obstruction. That basically tells you everything you need to know about the stakes here. This absolutely isn't a let's wait and see kind of condition. It's an immediate life or death race against time to prevent irreversible ischemia.
Okay, let's dive into this. Here is our roadmap. 1. Classification and pathophysiology. 2. The threat of strangulation. 3. Clinical assessment and signs. 4. Imaging the obstruction. And 5. Surgical management principles.
Section 1. Classification and pathophysiology. The anatomy of a blockage. So when this internal plumbing fails, the whole system backs up, and the distension you see isn't just trapped food. It's actually a massive buildup of gas from bacterial overgrowth, alongside pooled digestive fluids. We're talking saliva, bile, pancreatic and gastric secretions that just have nowhere to go. When looking at the culprits for this backup, the data is pretty striking. Post-operative adhesions account for a massive 40% of cases in Western countries, followed by carcinoma and inflammatory conditions. This statistical breakdown is absolutely crucial. Why? Because if a patient comes in with a surgical scar, adhesions instantly become public enemy number one. It's also fascinating that not all obstructions are created equal. In dynamic obstruction, the bowel is actively, sometimes violently contracting. Its peristalsis is working really hard against a physical, mechanical roadblock. But in adynamic obstruction, well, there's actually no mechanical block. The bowel is simply paralyzed, like in a paralytic ileus. This distinction is the big why this matters anchor, because it literally determines whether you're rushing to prep the operating room or if you can afford to wait and manage the patient conservatively.
Section 2. The threat of strangulation, a ticking time bomb.
And this brilliantly illustrates the cascading sequence of doom that happens when intraluminal pressure gets too high. First, that rising pressure compromises the low-pressure venous return. Basically, blood comes in, but it can't get out. This leads to massive swelling, which then physically chokes off the high-pressure arterial supply. The result? Hemorrhagic infarction, dead tissue, and the terrifying release of systemic endotoxins directly into the bloodstream.
Now, one of the absolute fastest ways to trigger that exact cascade is a closed-loop obstruction. This happens when the bowel is blocked at 2 points, both proximally and distally. Imagine pinching the balloon at both ends. It becomes a literal pressure cooker inside the abdomen. The distension is completely confined, the pressure spikes incredibly fast, and necrosis and perforation follow right on its heels. Another fascinating yet highly dangerous mechanism is intussusception. Think of a telescope collapsing in on itself. One portion of the gut invaginates, or slides right into, an adjacent segment. In infants, this is often idiopathic, or viral, presenting with sudden screaming episodes. But in adults, that almost always means there is a pathological lead point physically dragging the bowel forward, like a polyp or a tumor.
Then we have the volvulus. This is a severe mechanical twist, an axial rotation of the bowel completely around its own mesentery. It's kind of like twisting a garden hose, but way worse, because the mesentery contains the bowel's entire blood supply. A twist of more than 360 degrees doesn't just block the tube, it immediately strangulates the tissue.
Now, what's really interesting here is looking at the physical mechanics of strangulation up close. Here you can see a loop of bowel trapped by direct pressure at a super tight hernial orifice. That mechanical ring acts exactly like a tourniquet. You can visually understand how local pressure directly and forcefully kills the tissue trapped inside that narrow little gate.
Let's contrast two really vital scenarios regarding the large bowel. Say a patient has a malignant stricture in the colon. The outcome heavily hinges on the ileocecal valve. If that valve is incompetent, the massive pressure can actually vent backward into the small bowel, which buys you some time. But if that valve is competent, acting as a strict one-way door, it creates a deadly closed-loop obstruction. The colon, particularly the cecum, basically turns into an overinflated balloon that will eventually rupture if it isn't decompressed.
Section 3. Clinical assessment and signs. Detecting the threat.
Bedside diagnosis relies heavily on what we call the classic quartet:
That's colicky abdominal pain, distension, vomiting, and absolute constipation, which means neither feces nor flatus is passed at all. But here is the ultimate red flag you have to watch out for, a shift in the pain. If that wave-like colicky pain suddenly becomes constant and severe, especially if it's accompanied by localized tenderness or shock, the obstruction has likely strangulated. Constant pain screams ischemia.
Section 4. Imaging the obstruction, visualizing the invisible.
Imaging is where we confirm what our hands and our patient history are already suggesting. On one hand, we have the classic plain radiograph showing that infamous ladder pattern of gas-filled loops, clearly displaying the valvulae connivenes of the small bowel. On the other hand, we step up to advanced imaging with the CT scan, revealing the striking target sign that is super indicative of an intussusception. CT is incredibly accurate and really helps us hunt for those subtle, early signs of compromised blood flow.
Reading these films accurately is an absolutely crucial skill. This breakdown shows exactly what you're looking for. Small bowel obstruction is characterized by valvulae connivenes. These are regular lines that cross the entire diameter of the bowel, kind of like an accordion or a concertina. Large bowel obstruction, however, features haustral folds, which are irregularly spaced and definitely do not cross the whole width. Why this matters is profound. Correctly identifying these features pinpoints the exact location of the blockage, which directly guides the surgeon's scalpel.
Section 5. Surgical Management Principles. Stopping the clock.
Let's see how this builds, because there is an absolute non-negotiable order of operations here. You don't just rush the patient into the OR. First, you must decompress the stomach with a nasogastric tube to prevent aspiration and get that pressure down. Second, aggressive fluid and electrolyte replacement using Hartmann's solution or saline is mandatory to reverse the massive fluid loss into the third space. Only after these resuscitative steps, unless of course there is active strangulation, do you proceed to step 3, surgical relief. Remember, resuscitation precedes the scalpel.
Once the abdomen is open and the obstruction is finally relieved, the surgeon faces what is arguably the most tense intraoperative moment, assessing the damage. They literally have to physically inspect the bowel to decide if it lives or gets resected. They look for color. Does a dark segment become pink and lighter when it's freed up? They look for circulation. Can they actually see visible arterial pulsation in the mesentery? And they check the musculature. Is it firm with returning peristalsis, or is it just flabby, pliable, and dead?
So what does this all mean? Well, it boils down to a matter of profound clinical judgment. When the clock finally stops on the operating table, a surgeon's ability to accurately read a tissue's viability dictates whether a patient keeps their anatomy or wakes up with a stoma. It's a pretty powerful reminder of just how quickly physiology can turn fatal and how vital swift, structured intervention truly is. When the clock stops on the operating table, how do you decide if the bowel can be saved? I hope this explainer illuminated the incredible stakes of intestinal obstruction for you. Keep learning, and we'll see you next time.